So welcome everybody. I'm Peter Burney. I'm going to chair this session. Majid's away at the moment. And so welcome. Just a little word for those who haven't been before. These global health fora are set up really to bring together people from different parts of the college and also occasionally outsiders as well to discuss issues relevant to health in low-income countries. The idea is to get people from different parts of the college who wouldn't normally talk to each other in the corridor, as a matter of course. If any of you have an idea for a forum that you think would be good, that you'd like to bring people from other bits of the college together to discuss things, let me or Majid know. We'd always welcome new ideas. So we meet by and large, every now and then we have to change this, but we meet by and large every third Thursday of the month. So we make it regular so that people can put it in their diaries. And you're always welcome to come. Rothschild Lecture Theatre is extremely difficult to find for most people, you noticed. So we usually have a few people dribbling in during the course of the talk. So the organisation is the Institute of Global Health Innovation, and Joe and Nikita very kindly do all the arrangements for this, so it's no trouble for me and Majid. And the organisation as a whole has what its title implies. It's very heavily loaded towards health innovation and also particularly technological innovation. But amongst the other things they do is they look after this Global Health Forum and a number of other fora. You can look them up on the website at Imperial and see all about it. I have to remind you that the event will be recorded, and there is also a lot of Twitter and various other things going on. If you understand about these things, you're better than I am. But anyway, there is a Twitter feed, and there is the other thing that there is, but I can't remember what it is. Jane may remind me. But beyond that, we will be recorded. They usually do a live, slightly edited version that goes on the web, so that's just to warn you that that will happen. So the first speaker is Stephen Matlin, who is a professor here, a visiting professor here at the Institute. He started a very respectable life as a chemist and worked in chemistry in low-income countries, and now has a much more broad view of low-income countries, and he's going to talk about migrants and health. Stephen.
So thank you very much, Peter, and thanks to the Institute for the invitation to come to this forum and to tell you a bit about some of the work I've been doing in the area of migrants and refugees' health in the last couple of years. And I first became involved in this area as a result of an invitation from a Franco-German intergovernmental cooperation called the Centre Virchow Willemey, which was set up in 2013. And amongst other things, it organises joint conferences between French and German people working in the field of global health. And in 2015, they decided that they needed a native English-speaking person to be involved with them in order to produce reports and publications from their meetings. And I was asked if I could lend a hand with that. The second connection through them is with the World Health Summit and the M8 Alliance, because some of the people in the CVV overlap with the people who are members of the M8 Alliance and who organise the World Health Summit every year in Berlin. And Imperial College is a member of the M8 Alliance, one of the founding members. There are now 25 or more, plus very many national academies are associated with the M8 Alliance and the World Health Summit. And they also have an interest in the health of migrants and refugees. And between these two organisations, I've been involved over the last couple of years in a series of 4 meetings. The first was in Berlin in early 2016 on the nexus of climate, migration and health. Towards the end of last year, they organised a side event at the COP22 UN Climate Change Conference in Marrakesh, which I also produced the report. And earlier this year, the World Health Summit held its first regional meeting in the Americas, and I reported on the session that was organised there by the M8 Alliance on migrants' health. Most recently, in June this year, in Rome, the M8 Alliance organised its first ever 2-day expert meeting, and this was again on the subject of migrants and refugees' health. And I was asked to produce not just a freestanding report, but a paper for publication. And we've just recently submitted that to a leading public health journal and still waiting to hear the outcome. So I want to give you just a flavour of some of the things that I've picked up from this series of activities I've been involved in, and particularly at the end talk about some of the key points from the paper. From the abstract introduction to the paper, I just want to highlight what's really a summary of the current state of affairs, that by and large, although there are an increasing number of migrants and refugees in the world, their health is increasingly neglected and poor in many places, and they often fall in the cracks between the national service providers and the international sources of humanitarian relief. So they often have a rather desperate health situation. It's important to recognise the meanings of terminology used in this field. And first of all, the International Organization for Migration, which is based in Geneva, very simply and comprehensively defines a migrant as any person who has moved either across an international boundary or internally in the country to be away from their usual place of residence, regardless of the reasons for that. Refugees are much more precisely and closely defined through a series of international conventions, protocols and declarations. And these are people who are away from their normal place of residence, who have fled or fear to return home as a result of very well-found fears of persecution or discrimination of many kinds. And the Cartagena Declaration expanded the range of things that could be used to help classify people as refugees. And an asylum seeker is a person who has applied for asylum or refugee status in a country but has not yet received a final decision on the application. And again, this is important because refugees and asylum seekers have rights that are agreed to by these various international treaties, which almost all the countries in the world recognise. They have rights which go far beyond those of simple migrants. And as a result, the terminology that's used to describe these people is often hotly contested, both politically and in the media. It's much easier to send packing people who are classified as economic migrants than to ignore the plight of people who are recognised and accepted as refugees and people with asylum or asylum seekers. So, looking first at migration, the overall picture is that there are currently about 250 million international migrants in the world out of a population of around 7.5 billion. And that number has actually been relatively stable as a proportion of the global population for a number of years. It's run between about 2 and 3% over several decades now. One interesting thing that's not given very much publicity or attention in this country is actually that the UK itself is a major source of migrants to other countries. It is in fact the 10th largest source of migrants in the world. And migration is not an exceptional phenomenon, it's not a short-term phenomenon, and it's not likely to go away. In fact, it's rather likely to increase. This circular plot showing international migrations within a period of 5 or 6 years illustrates this. There are lots of migrations within regions and across between regions, so that we need to accept that migration is not exceptional. It's a structural phenomenon at the present time. It will go on being a structural problem and is likely to keep increasing for a whole variety of reasons in the coming decades. But there are often inadequate or discriminatory provisions for the health of migrants, and especially for those who don't have regular status, who are so-called undocumented. And it's therefore very important to search for solutions that do recognise migrants, refugees and asylum seekers as part of society, as part of us rather than part of the other, and to regard them as structural rather than external. This isn't what happens in practice in many places, and for example, many European member countries have very restricted health rights that they offer to particularly undocumented migrants and undocumented refugees. And some of them explicitly say that they do this to discourage the entry of new migrants from other countries. I'm not going to say more about Europe because I know that Sally Hargreaves is going to be talking in detail about the situation in Europe in her talk. But to stay with the broad and global picture, in 2008 the World Health Assembly had a resolution on the health of migrants, and the list of things that it calls on its member states to do is a very good catalogue of all the things that are not being done or not being done well. So without reading through it in detail, you can see that it covers policies, access to a whole range of health services, the need for better health information systems, for sharing of information and best practices, need to improve cultural and gender sensitivity amongst health service providers and to train health service professionals better, and to have more international cooperation. So all of these things are very much areas that have been problems and are ongoing problems. Turning to refugees now, in 2005 there were about 37.5 million people in the world who'd been displaced by war and internal conflicts in countries. And this rose modestly through to about 2012 when there were about 45 million displaced people due to war. But then it began to rise steeply up to 59.5 million in 2014 and over 65 million by the end of 2015. That was a 75% increase roughly in the space of about a dozen years. And at this point, people began to talk about the refugee crisis. And this refugee crisis is indeed a new phenomenon. It represents the largest and most rapid escalation ever in the number of people being forced from their homes, and the highest overall level of displacement since the end of the Second World War. What's important to recognise, though, is that most of the people who are displaced from their countries remain close to their original countries, and that means they remain mostly in low and middle income countries. In fact, in 2015, over half of the refugees worldwide came from just 3 countries, Somalia, Afghanistan and Syria, and the top hosting countries were all low or middle income countries. But in 2015 and 2014, we also saw a massive jump in the number of migrants and refugees coming to Europe. And this was one of the factors that elevated the issue on the political agenda, both within Europe and globally. Just in 2014 alone, about 2.3 million new migrants arrived in Europe. And in preparing for a UN high-level summit in 2016, UN Secretary-General Ban Ki-moon tried to put the whole picture into perspective by emphasising that this is not a crisis of numbers, but a crisis of solidarity. Most of the world's refugees are hosted in developing countries. 8 countries have more than half of the world's refugees, and only 10 countries are providing about 3/4 of the assistance that the UN receives to help the people in their plight. And the President of the European Commission, in his State of the Union address to the European Union in 2016, also recognised the health dimensions of this European refugee crisis and reminded European countries that they have a common responsibility to ensure care and support, including through the provision of health care. So in September last year, there was the first ever UN General Assembly high-level summit on migrants and refugees, and every member state of the UN signed up to what's become known as the New York Declaration. And health features at quite a few points in this declaration and emphasises obligations that countries have to, or commitments that they then made to look after various aspects of the health of refugees. But the onus of responsibility for looking after the health as well as other aspects of the welfare of refugees and asylum seekers remains with countries. And the reality is that so far it appears that there hasn't been much solidarity from the international community. There are exceptions to that, and within Europe, for example, Norway, Sweden and Germany have all been quite welcoming and quite generous to migrants and refugees. But this can come as at quite a high political cost, as Germany has found during the last year or two. WHO last year produced a new report on the health status of migrants and refugees and emphasised again a whole list of ongoing problems in the area that really need attention. So there are many risks to the health of migrants and refugees, and they start before they leave wherever they've come from, and they go on after they've arrived wherever they're going. So before the migration process, the health status of people who are going to end up leaving is, of course, affected by all their local circumstances, starting from whether there's a good health service and whether they're generally well looked after in normal conditions, education level, genetic makeup, all sorts of factors, but also, of course, the special events that may eventually cause them to move, whether it's natural disasters or man-made events and conflicts and traumas and so on. During travel, they may be subject to extremely perilous and unpleasant conditions and physical and various forms of assault and ill treatment, unsanitary conditions, lack of good nutrition and so on, which can contribute to bad health. And at the transit and destination point, where they do begin to receive care and attention, there are all sorts of service factors, cultural factors, worries for the individual, uncertainties and so on that contribute to poor physical and mental health. Having recognised that these are all potential problems, though, it's important to say that in many cases what you actually see is a healthy migrant effect. It's often observed that migrants arriving in host countries are healthier than the comparable native population, and this can be because of positive self-selection amongst the immigrants themselves, the younger and fitter people being sent abroad to find their way and make a living, or it can be due to discrimination by the host countries, the destination countries that are looking for fit, healthy young male workers, particularly, or female workers for some areas. And so they filter who comes in. But this healthy migrant effect may not be seen in the case of refugees who've had very difficult and dangerous pathways to their destination country, and especially if they've spent long times in intermediate transit or refugee camps. And whatever their status when they arrive, it may get better, but sometimes, and quite often in the long term, it gets worse, because migrants and refugees, once they're in the country, apart from the question of what level of health care and attention they actually receive, they tend to adopt their lifestyles and their diets to their new surroundings, and very often that means that they move from infectious diseases to non-communicable diseases and so on. And so Alexander Kramer, who was one of the participants in our Rome expert meeting, produced this kind of hypothetical scheme of what tends to happen with different disease states. And for example, with infectious diseases and injuries, which may have been acquired at the source point or along the way in the travels of migrants and refugees, if these are treated, they'll generally get better reasonably soon. Whereas in the longer term, cardiovascular disorders, diabetes, cancer and so on, a whole range of non-communicable diseases tends to increase over time. Mental disorders are a particularly complicated area. if mental disorders caused by trauma and so on are particularly acute at the point of arrival, they may get noticed and treated, but often they tend to be in the background and get ignored. They may resolve once some of the stresses go away and people are able to settle in, but often recur later in the form of post-traumatic stress disorder, long-term depression, feelings of isolation and loneliness if people are away from their families and communities, and a whole range of new disorders can appear. One of the interesting effects that's been seen in a number of countries is that suicide rates in first-generation migrants are often lower than those in the background population, but in subsequent generations, second and third generation immigrants, can sometimes be higher. So there are some complex background effects going on there. So as well as a healthy migrant effect, there also is very often seen a productive migrant effect in which the people who come in are very industrious and enterprising and often contribute quite significantly to the economies of their new countries. And this has been shown by reports from the World Bank and OECD, amongst others. But this is the opposite of what many people think, and many general population policymakers in destination countries often fear that immigration will lead to competition for jobs, driving down of wages, imposition of heavy burdens on public services, erosion of social cohesion, and increased crime levels. Quite the opposite of what's actually observed in practice in many places. And another facet for migrants is that they're often in the most precarious and least secure jobs, so they're often the first to feel economic pressures and find lower wages or become unemployed. A lot of this disconnection between the reality and the perception is due to the way that representations and framings of migrants and refugees are made, both by politicians and in the media. So, for example, this is from a technical publication some years ago, illustrating where typical migrants to Northern Europe come from within the European Union. And it's technically accurate, but can easily give an impression of that there are hordes of migrants waiting, coming to invade Northern Europe. And this is precisely the kind of thing that newspapers can pick up on. For example, this Express headline, "Migrant hordes hell-bent on reaching soft-touch Britain." And these framings go generally to the way that migrants are perceived. These boatloads of people clinging for their lives can be framed either as people at risk or people who present a risk. And similarly, people who are being displaced from war-torn countries where there is serious conflicts going on can be presented as people requiring assistance or simply as potential new threatening hordes to invade. And just occasionally you find photographs which are so moving that you can only see a sympathetic response in the newspapers, but these tend to be quite short-lived. So very often what you find in practice is that a sort of keep-out syndrome develops in countries, and keep-out mentality. And one of the ways that manifests itself is in the number of walls and barriers that are built at the borders of countries. And this chart shows what's happened since the middle of the last century. And you'll see that the number of physical walls and barriers remained fairly steady and was typically around 15 or 20 in any one year, until about 15 years ago, a dozen years ago, and coinciding with this sort of big upswing in the number of refugees around the world displaced from their homes, you see this quite large increase, tripling in fact, in the number of walls and barriers. And these are quite popular with some people who think it's a useful political response, but not everybody agrees. So I mentioned at the beginning the nexus of climate migration and health, climate change migration and health, and I just want to very briefly, if I've still got a minute or two, just talk a little bit about that. Climate change, of course, has many direct impacts on health, and it poses a serious threat, including because of extreme weather events that can directly result in deaths, also loss of livelihoods and security, which can more slowly cause death, and the movement of vectors of infectious diseases such as mosquitoes moving into new areas and bringing diseases like malaria and dengue and Zika with them. Climate change also, of course, impacts on population movement, and in fact the IPCC, the International Programme on Climate Change, one of its first warnings back in 1990 was that migration was likely to be one of the biggest effects of climate change in the 21st century. And it's been estimated that anything up to 250 million people per year may be displaced by the later part of the century as a result of climate change. And of course, as we've just been talking about, migration itself is a serious risk factor for the health of people, both those who lose their lives in the process of movement and those whose health deteriorates as a result of all their experiences. So there's an important connection between these three, and one of the factors, of course, is just simply the rise in sea level that comes from global warming. And this map illustrates what a sea level rise of just 1 centimetre would do, which is to put about 1 million people around the world at risk of displacement. What that means in real terms isn't something for the future. Let's have a look at the situation for Cotonou, port on the coast of Benin in West Africa. There's a map of the town, a Google map, and you see the red flag on the right-hand side. And we're just going to look at the area around that red flag now. And here it was in 2002, and you see here the coastline marked in red. March 2004, the coastline has moved northwards. November 2011, it's moved quite significantly further, and by November 2013, here it is again. So in a period of about a dozen years, that much territory has gone as a result of encroachment of the sea, but also you'll notice this area became blank because the houses there were destroyed by the authorities because they could no longer keep that area from becoming inundated, and so it was made uninhabitable. So this is what the present picture looks like. If you think that's still a bit far away from here, these are the projections for London. On the right side you see with a 2-degree warming, which is improbably low now. We're not likely to keep global warming that low this century. Much more likely is about a 4-degree warming, and you can see that quite large areas along the London basin are at risk of floods and inundation. So my last slide now is to come back to the paper that we just submitted for publication, which proposes an agenda of solutions to provide a comprehensive framework and bringing together humanitarian, ethical and rights-based concepts behind it. And just very quickly, it includes a framework which normalises the issue of migration as a constructive and adaptive response to local realities, the need for policies based on these principles of right to health, equity and social justice, intensified international collaboration, early attention to both physical and mental health issues, expanding the education and training of health professionals, and especially the need for them to be trained in cultural or transnational competence, and the need to support research agendas because we just don't have enough good data. The need to encourage academics to use their position, both their knowledge and their independent status, to be a voice to correct some of the misinformation and misapprehensions that there are around, and the need for national academies and professional bodies to also contribute to that. And very importantly, and last but not least, in parallel with dealing with all the acute and chronic issues of those who are displaced, the need to address the root causes of displacement, especially through addressing issues of conflict. So I'll stop there. Thank you.
I think unless there's some urgent matter clarification, we'll move on to the next talk and we'll have a general discussion at the end. Thanks very much. So the next talk will be given... Oh, not what I'd expected, but there we are. So, yeah, okay. So, Mohammed is now a public health doctor,
Thank you. Thank you. So before I start, and I know many of you have noticed the small tweak in the title, which is deliberate somewhat. Does anyone in the audience have citizenship with a country other than the UK? So if I pointed at you or you and said, you're a migrant to this country because you temporarily or permanently live in a country other than that of your citizenship, you may feel slightly stigmatized or may not identify with that kind of terminology. But often when it's the other way around, and many of us go to other countries, usually earning six-figure salary, we like to refer to ourselves as expats. But actually migrants and expats mean exactly the same thing. Usually it just depends who you are and the social constructs as the definition. So I was asked to speak about refugee health in the Middle East, and as was described in the previous lecture, refugees have a particular legal meaning. Not all of the people who are vulnerable or displaced in the Middle East are in fact refugees. Many refuse to register with agencies that give them such status. So it's quite hard to define who they are. So maybe I will use the term expats to describe them more aptly. It's more of a holistic approach. So I'm doing a PhD on conflict and health in the Middle East. I've been living in Lebanon for most of the last year or so, and thought I'd just give an overview in 15 minutes of some of the issues in the Middle East. Of course, 15 minutes isn't enough to talk in detail, so I'll try my best. You've seen a few of these pictures before already. We know that the Middle East is one of the big areas of the world that are responsible for displacement of people. This was one of the latest diagrams in the middle from UNHCR saying that over 50% of refugees come from these three countries. I would dispute it and actually say if the UN agencies recognize Palestine as a country, then Palestine and Syria alone would be responsible for over 50% of refugees worldwide. And actually many of them do tend to spill over into neighboring countries. So most of the Syrians are in Turkey, most of the Afghanis are in Pakistan. Again, mostly Syrians are in Lebanon. The Middle East is a complicated area. Over half of the countries are in a state of conflict, and the red lines denote relationships that are somewhat strained, the darker lines relationships that are somewhat supportive, with the dotted lines somewhere in between. And you can see often groups and countries are in conflict against their friends and against their enemies' enemies. It's hard to know sometimes what's going on, but what we do know is that it's caused a massive amount of displacement. I wanted to put this picture up early on. This was a last-minute addition to my slides. This is a picture of the early refugee camps resulting from the Arab-Israeli war. It's a Palestinian refugee camp. And the reason that this is such an important picture is because most of the refugee issues today are rooted in a history that stems from the Palestinian crisis. That camps have been built since 1950 and still remain today, not so much in the tent form, but actually as physical structures, still refugee camps. And that's really affected new waves of refugees in the region. So there's a status quo bias that must be appreciated. I'd like to focus on Syria. It's an area which I've been studying somewhat closely. Here are just two maps that identify just how dynamic and changing the situation is. Roughly speaking, the red areas are areas of territorial control by government forces. The green areas and yellow areas by opposition forces. And the black areas from what the so-called Islamic State forces. And you can see these huge changes in territory. Actually, maps like these change on a monthly basis. And the movement of vulnerable people, of these expats in Syria, are strongly dictated by who's owning which areas and driven through sectarian lines. So where are the refugees or the expats from Syria? Actually, the vast majority, about half of all Syrian refugees, of all vulnerable Syrians, expats, shall we say, are inside the country still. And people might say, oh, well, that's okay because they're in a local area, they've probably just gone to their neighbors or still have access to all the same things as before. But actually, these are among the most vulnerable. We know very little about internally displaced persons inside Syria because often they go to different provinces and they are known to be foreign to that local area and therefore refused access to basic services, to school, to labour opportunities and so on. As mentioned before, the majority of those who are externally displaced end up in neighbouring countries, with a tiny minority going to Europe. Actually, I think the number of Syrians who are in Europe constitute about 3 or 4% of the total number of Syrians registered in neighbouring countries, the neighbouring Arab and European countries. So these numbers are always changing and probably a bit it's very hard to keep a close, accurate eye on these due to registration and deregistration procedures and dynamic movements between countries. But of the approximate 5 million refugees in neighbouring countries, majority are in Turkey. There was a recent EU-Turkey deal that effectively bribed Turkey to keep refugees in there and actually said, if we ever find a refugee that's left Turkey to a neighbouring European country, this deal means that we're allowed to send them back to Turkey. So Turkey has the most. That's not to neglect areas like Lebanon, which 1 million may not sound like a lot compared to Turkey, but when the country only has a baseline population of about 3.5 million, the per capita number of refugees is huge. And they're really struggling with managing nearly, increasing their population by a third overnight. Jordan's an interesting case. Many of the refugees who go to Jordan are children. And we're not sure why this is. Jordan could be seen as a safer place for children to go, and often we see that families might send their children alone to other countries for various reasons. And that comes with it a whole host of vulnerabilities. Iraq has problems of its own, as you know. That's where I'm from. But actually, to even think about Syrian refugees going to Iraq just must tell you how relative destruction that's going on in that country. And we have other areas, Egypt, North Africa in general. In contrast, Europe's only taken about 1 million in total. Half of them have gone to Germany. They've been very receptive. So too have Canada. Canada receptive of all forms of migrants. I think economically they need many people, so there's very, very low barriers to entry there. Sweden and the US make up the remaining top 4 Western countries that have taken Syrian refugees. Interestingly, among those in Middle Eastern countries, only about 10% of the refugees are in camps. So this is one of the first humanitarian crises where building refugee camps is not the norm. And that has implications on health, of course, as I'll explain. This is a slightly outdated picture, but I thought was very interesting to see that the Gulf countries have taken a grand total of 0 refugees between them. It looks like a very, I said the political situation is very complex in the region. Even with that picture, Kuwait has been one of the largest funding contributors to the Syrian refugee crisis, about 50 million over the last 6 or 7 years. I hadn't seen much funding from the other countries. But this feels, it fits in with a narrative of building walls and keeping people out of countries, so to speak. So I wrote a blog, a short piece on World Refugee Day this year about my daily walk to work in Beirut, in Lebanon, which really did emphasize and it really was symbolic of the wider situation that was going on. I saw refugees on the street who had appeared to have a variety of chronic diseases, mental health problems. The demographic of what I was seeing was reflective of the wider situation, and it was quite quite sad and quite difficult to be exposed to that on a daily basis. And I think many of us like to just hide away and pretend there's no problem. But if you do manage to have a read of that, please do. So I'm in the policy evaluation department over at Charing Cross Hospital. So policy is important to me, and I feel that parties that have signed up to the 1951 Refugee Convention and its additional protocol appear to have a slightly better behaviour towards accepting and treating refugees, and therefore their health appears to be slightly better off. Of the countries we've spoken about so far, all of the European countries and Egypt are signatories to the 1951 Refugee Convention and its protocol. But unfortunately, where most of the refugees are, neighbouring countries, they're not signatories and therefore have no international obligation to develop policies that are supportive of refugees. I put a question mark for the United States. Because they have signed the Refugee Convention, but there's a big debate about the extent to which their laws actually fulfill. Either way, I feel that whether or not you're a refugee in the US, the healthcare system probably isn't great to look after your needs anyway. So, an overview of some of the policies in the local region. Lebanon has had an open border policy to Syrian refugees, but they haven't allowed the construction of camps at all. So you have these what we call informal tented settlements. A picture shows just that. As time progressed, Lebanon's legal laws became stricter on the refugees. Refugees, in order to live in the country, had to have a pledge not to work. So imagine how desperate people must be to actually say, yeah, I pledge not to work. So you have doctors coming through. They're only limited to 3 sectors of work, one of which is agriculture, another which is hospitality, and the other is, can't remember, but it's very kind of manual labour work. So doctors are often seen as cab drivers or as working in restaurants as waiters, or illegally treating patients when they shouldn't be allowed to, risking illegally, they can be imprisoned for that. So Lebanon is a real problem with increasing and stricter regulations on refugees. Their system is actually quite fragmented anyway. It's a mixed public-private healthcare system. And if you do register with UNHCR, then there's a minimal fee at most public centres. However, the out-of-pocket expenditure has increased substantially per person per year, from about $90 to about 150. And I would say Lebanon is one of the most vulnerable places for a refugee or vulnerable person to live, purely because the opportunities for work are small, and therefore you fall into a cycle of deprivation and hardship. Like Lebanon, Jordan has also had an open border policy. Remember, they too are not signatories to the Refugee Convention, but unlike Lebanon, they have established a number of camps, and this is actually one of the camps called the Zaatari camp, which is in the north of Jordan. That's been constructed. It's actually the 4th or 5th largest city now in Jordan, this refugee camp. Although only 10% of people live in these camps, those who decide to live outside of the camps are actually very vulnerable. 90% live below the poverty line. Factor in that those inside the camp are probably less well off than those who decide to leave. Jordan was interesting because initially it offered free healthcare access for anyone registered with UNHCR, and then that was rescinded a couple of years later. Instead, they were treated as uninsured Jordanians. Therefore, we see similar increases in out-of-pocket expenditure as in Lebanon. However, I still feel that the Syrians in Jordan are probably slightly better off than those who went to Lebanon. And lastly, just to mention about Turkey, they've had an open border policy, and I've already talked about the EU-Turkey deal that left, kept a lot of refugees there. They have this legal status called temporary protection for Syrian refugees, which does fulfill the requirements of the Refugee Convention. It basically ensures that the principles of non-refoulement, i.e. people are allowed to stay for an unlimited amount of time without fear of being sent back home. They have built a number of camps in Turkey, mainly along the border with Syria. However, most don't live in camps, as mentioned. Most that live have integrated into towns and cities. Healthcare access is actually still theoretically quite good in Turkey. They still have free healthcare access if registered with UNHCR, and actually there are schemes where they've built these migrant health centres which allow Syrian doctors to treat Syrian patients, pending some training on the Turkish healthcare system. So there is an element of integration. Syrian refugees there have gone into the cities, opened up stores, built lives. There has been some restricted border access now going back into Syria. So there's no longer free movement if you leave to come back in. So people have decided to kind of stay resident. And I suspect Turkey probably has one of the best health outcomes among their Syrian refugee population. This picture shows some of the main migration routes through the Middle East or East Mediterranean and East Africa. There's a bunch of arrows everywhere, and the reason I put this up, as was discussed in the previous lecture about the healthy migrant effect and the problems associated with the health problems associated with all this travel. So those who decided not to leave Syria are probably slightly older, slightly more vulnerable and less able to move than those who did. However, there may be this kind of gradient of poorer healthcare access the closer the person stayed to Syria. There are refugees who are camped along the borders of Syria, those who have decided to move into Turkey or come through Jordan and North Africa. We've heard stories of Greece, particularly areas like Lesbos, being absolutely overwhelmed with refugees who are stuck there. Some of them have been stuck there still for years. There's been a wall has been built in areas of the Balkans, which has stopped refugees from using that route. And those who do end up making it to mainland Europe, to Western Europe, maybe those who have slightly more money, more contacts, and again, most likely better health. An example of this is, I'm not sure if anyone has read the story of Yusra Mardini, who was a Syrian refugee who actually took a boat across the Mediterranean. The boat capsized and she was swimming to safety, but also her and her sister saved and countless others who were also drowning. And she's now become not only an Olympic athlete swimmer, but actually a goodwill ambassador to UNHCR. So her story is really fascinating, but really does exemplify this healthy migrant effect. The fact that she could swim and was healthier and younger enabled her to really get to where she is now. Syria is is not a low-income country. It's a middle-income country. Had already undergone the epidemiological transition by the time the conflict kicked off, and therefore one of the biggest health problems uniformly across the refugee and vulnerable population is non-communicable disease. That, coupled with the traumatic experiences of either staying in Syria or moving out of Syria to other countries, means that mental health features quite high on the agenda. But actually, given many of the displaced individuals were women and young children, especially to neighbouring countries, here gender-based violence becomes a real concern. Communicable diseases, as mentioned as shown in the previous lecture, tend to kind of resolve quite quickly once identified and managed. But actually, there's been some major concerns of communicable diseases among children. For example, there was a polio outbreak, a re-emergence of polio in Syria among children after about 20 years of it being completely eradicated. That then spread to Iraq, which has been under conflict for 30 to 40 years now officially, and the vaccination issues have been a problem with children. So I think communicable diseases certainly should feature there as well. So I think that's all I have to say at this brief overview. Happy to take any questions later on. Thanks for listening.
Hello. Thank you for a very interesting overview. I have two comments that will lead into a question. My first comment for Muhammad. It's interesting if you're talking about refugees, expats in the Middle East, and mentioning the Palestinians. It'd be nice if you could actually talk through what UNRWA has done in terms of health provision for the Palestinian refugees, because I think it's a great example to contrast in what is a dire situation. That's a comment. The second comment is I thought it was very helpful. I think it was the first, Professor Madeline, when you gave the definitions of what migrant versus, and now I'm getting muddled up because I got more muddled up going through, but the definition of a migrant and then refugee and asylum seeker. And I think I lost the definition, or whether there's a stratification that needs to happen in the other, in the following talks. So particularly in the last two talks, does your definition of migrant encompass refugees? And is this kind of a Venn diagram, or are we talking about concentric circles? Because I'm assuming that the profiles of these subgroups would differ and kind of skew some of these results. So in some of the migrant data that you showed around TB, the reason of them being in the country was either work and study. So I'd assume that'd be very different than an economic migrant versus refugee or asylum seeker. So that would kind of skew your outcomes. I'm just a bit confused, I think, in the nomenclature and what the outcomes look like for that. So.
I mean, I think the thing, so this is a big problem, definition. So you can define refugee according to the UN Convention, you can make definitions, but everybody uses them differently. So we tended to use migrant as someone who's been in the UK for less than 10 years, come from another country, but often the country they've come from is not the country from which they were originally migrating, clearly. And so when we do studies, we look at it very broadly. It's also very hard to know why someone is actually migrating. Ask them, are you an undocumented migrant and you're sitting in A&E? The chances are you're not going to say yes. You just ask them what kind of migrant they are, but they don't. I mean, student is what is a student? I don't know really. I think it's very hard, and I think the thing is not to get too bogged down in all these terms, because everyone, and when you write, we've had this problem when we're trying to write things. Some other countries much prefer to talk about refugees, even when they don't have refugee status, but they see them as refugees. So I'm not sure what you should call them, but I do kind of feel you shouldn't be sick dividing into different groups, sort of trying to salami slice them for who they are too much, because it's quite hard to get that work out.
Perhaps I could just add to that. I point out early on that the IOM doesn't like to subdivide migrants, anybody who's moved from their normal place of residence. And I think in many ways that's a defensible position, both for political reasons, because once you start using terms like economic migrant, and secondly because technically, as has just been alluded to, it can be extremely difficult to classify people if you start subdividing migrants. Migrants often have a very long and complicated pathway between where they start from and where they end up. To give you one example, people who were poor agricultural workers in the interior of Senegal and who found that land degradation and climate change was making it untenable, moved to the north coast of Senegal, Port Louis, where there was a very good living originally to be made from fishing. Quite a different area of work, and they moved in the hopes of getting work. But when they got there, they found that, in fact, population increase and overfishing meant that there wasn't much of a sustainable livelihood there. So some of them moved on, often without documentation, to Mauritania, further north. Some of them were persuaded by people smugglers to make a longer journey and head across Africa and up to Libya, where they found the conditions absolutely appalling. People on. And so they decided to risk their lives by scraping together the last money they could find and giving it down on the way in somewhere like southern Italy. Now, are those people economic migrants? Are they environmental migrants? Are they political refugees? Are they victims? They're all of those. And how they might describe themselves if you ask them, why did you come? Can be very complicated. And again, if legally we're trying to decide what kind of migrant they were, it would be an absolute nightmare. Refugees have a recognised status. They're a subgroup of migrants, a subset of all the people who move, and they have a defined status in international terms, but as has been mentioned, it's not always well respected in local situations. But at least if somebody is accepted as a refugee, in other words, really have been forced to move and cannot go back home lives, that's a very clear status, which should in principle give. So I think one shouldn't get too hung up on the status of people. But having said all of that, if you're really inquiring into what were the drivers, what made people move, it is very useful to think about the cause. Understand, for example, that people are usually first internally displaced. It's quite valuable to know that climate change and environmental degradation were the immediate cause of moving. And if you want to discourage people from needing to move further abroad, you have to look at what livelihoods, alternatives can be built locally. Origin. They are forced by circumstance to move abroad, and it will often be to a very nearby country. What are the things that would persuade them to stay there? Well, obviously access to the means of livelihood, to some healthcare, to some educational opportunities for their children. And if they don't get those, then many of them will decide that they need to eventually move on. Otherwise, they're going to spend generations living in a refugee close to home, which is not.
But they're not going to be the problem of people.
I think maybe you can, I mean, true refugees, for example, in the UK are a tiny proportion of the problem. Minimal. Not that there are not many refugees, but people who are defined by the government as being refugees and granted asylum. But you can sort of split migrants into undocumented migrants and migrants, which is, I think, what we like most of them. You have, and they both have problems. I mean, as you say, they're different. But I think beyond that is quite difficult. And I think it's also quite difficult to find out what people do unless you spend some time doing a qualitative study, talking to them. You ask them in what is, they've already gone to a chaotic A&E for something else, like they've fallen over, their leg. That is not the moment to be working out their migrant journey. We were just trying to see if we could screen them for diseases, might help them. And I think it's very difficult. It's really difficult.
Your point about our data, I mean, we've had huge issues with this, but certainly in infection, big data. Actually, foreign born, first. Actually, a lot. Migrants, or done for. Really fair. Wasn't
The last point about the NHS and the difficulties, as you've mentioned, John, in terms of chaotic A&E and generally, the reality is it's quite difficult for receptionist staff to be asking about your ethnicity. You know, you've come in with a broken leg. Why are you asking me where I come from? You know, etc. So I think that's one thing. And I think what struck me was the contrast between, say, Jordan, where the NGOs that I have links with talk about 1 million refugees, but 650,000. But the total population of Jordan, I think, is only about 4 million. So 20 to 25% of the entire population are non-Jordanians and have been welcomed in. The bars in the UK have been set higher and higher, so that, you know, even if you are married to a European that's not in the EU, you're paying a £500 bond or whatever each year. So it's difficult to see how, you know, we're going to get that humanitarian aspect unless we can get data that shows in a very hard way that if you don't address these health issues, you have unfortunate consequences to the local population. So we've looked at TB transmission in Oxfordshire and shown, in fact, that it's not transmission from the foreigner to the local person. It's actually transmission occurs within the white, indigenous, middle-class Oxfordians. So, you know, data that might show that that people are presenting with more severe illness because they're scared to come forward, and therefore there's a risk of greater transmission occurring to everyone else, might be the sort of evidence that pushes people in the Department of Health a little harder to do this. And the last part, you mentioned IOM. Well, I think you have a very nice slide. There are all sorts of odd biases. The IOM has a massive contract from the British government to supervise TB screening for active disease. 105 countries are screened. And of course, we're seeing a fall in cases of TB at the moment. And so the reality is that people are saying, well, we've tightened up our immigration controls and we appear to have a drop in TB cases, sort of the Daily Mail kind of, you know, concept. So, you know, we need quite a big pushback.
I mean, I think the only thing I would say is that you have to be very careful because, you know, if you're showing diseases, we showed a long time ago that people who come into infectious diseases wards, you know, migrants are sicker and they do worse. I mean, I don't know, it was 1999. But if you show people are sicker and they're spreading diseases, that's another reason not to let them in. And I personally think that's very dangerous, and I think the data that is positive is the data that the sort of things you've all touched on is that they are, on the whole, economically active, but we stop them working. I mean, it's not just neighbouring countries. You can't work if you're an undocumented migrant. You know, you can't. You're not allowed to work. You're not allowed to do things that gives you self-respect and contribute to the economy. And you know, history tells us from all around the world, you know, the USA is built on migrants, and many countries are. So I think health is a great place to have a battleground about why migrants are good for countries. And they're good for science, it's good to mix. You know, and it's always those areas of the country where there are the most migrants who are most sympathetic to them.
Sure.
It's where you don't see them that people are most hostile.
For example, in the currently Brexit debate, John,
I mean, the truth is, I mean, there's lots of truths, of course. But if I'm going to propound anyhow, is that we admit less migrants per head of population to the UK than any other country in Europe.
I hope this is not greedy, but I've got three questions. I'm the chair of the board of ICDDRB, which used to be the International Centre for Diarrheal Disease Research in Bangladesh. And at our board meeting a couple of weeks ago, we had a big debate about doing research among the Rohingya people, because ICDDRB is vaccinating them, providing them with new foods. but it's an opportunity to do all sorts of research. In fact, you'd feel we almost should be obliged to do research. But there was a lot of worry about, well, who could say it was legitimate to do research? Can the Ethics Committee of ICDDRB, which doesn't really know anything about the Rohingya people, so you called for more evidence, so how do you say, yes, it's acceptable to do research? So that's one question. Shall I go on with the others, or?
I can go one at a time. We can do one at a time. And so just my quick answer to that is, it's absolutely vital you include the migrants in your research and your research decisions and your ethics. And Sally raised that, and you carry on with that. But this is something absolutely critical. So, I mean, the diarrheal diseases Centre for Bangladesh does fantastic work, and has done for tens and tens of years. And but I think for this arrangement, you need to get them involved. And if you get them involved, you'll probably find you've got a winning.
To generalise from that point, the voices of migrants and refugees are usually absent from much here as it is in Bangladesh.
The second question is a very simple one. Who exactly defines whether somebody is a refugee? Is it the country? Because Bangladesh is not willing to call the Rohingya people refugees. Is it down to them, or is it a UN body that decides?
It has to be both in the end. I mean, a refugee is defined by international conventions and protocols. Has been enforced. On those grounds, you would think it's fairly obvious to the Rohingya. But it's up to each individual country to then accept them as refugees.
And the government wouldn't want to do that because it gives them all sorts of extra rights.
It would place them under obligations of all kinds,
including, for example, freedom of movement. I mean, if they're not refugees, if they were refugees, they could move anywhere in Bangladesh, could they?
Yes.
And then my third question is about economics. And you started, John, with your case of someone who'd been, 6 weeks in intensive care and 2.5 months in hospital. I mean, the cost of that is enormous. So surely there can be a sort of economic case for doing things further upstream. And I wondered if you'd done any studies along those lines.
We're very, very keen at this. So this is one of the things that interests me absolutely most. And Laura, who's behind you, is interested in it as well. It's where do you look for people's diseases, and where do you best find them? It may be hard to do some things on the migrant journey, but other things may be very effective on the migrant journey. Some things may be better done when they arrive, but they screen. Some things done opportunistically. Some things about making, and we don't. The answer to your question, we don't know the answer to your question, but that is a critical question, and I think one that for TB and for other things, but it is potentially a source of information and ammunition to say that by doing this, it's always double-edged because someone says, well, look how costly these people are because they tend to present late. Be a bit careful.
Yeah, I think the economic argument can be quite a dangerous one because if the economic benefit, say, isn't there, does that mean that the argument no longer exists? Like, surely the kind of approach we take is rights-based rather than driven by economics. So
Although you could argue that's clearly not happening, and governments do respond a lot to cost.
But I think it's the other economic side. It's the value of work. But we stop them working. I think that's the economics argument you can use the most. Is that because most people want part of their self-respect being able to work and integrate. People want to be involved. So I think that's where economics has a value.
yeah, I mean in Turkey there's been some research that shows that on a micro level the economic argument holds well, and there's a boost to the local economy through local work and so on. But actually on a macro level, GDP adversely affected, strain on the economy, slowing in growth. So that's what the research shows. How much do you want to wave the economics flag? Whereas if I think a rights-based approach, getting these countries to sign up to the Refugee Convention, pushing forward policy. are pro-equity and eating based on need
And-
rather than cost.
I think the thing about economics is it's like all these things, they're subject to manipulation.
Yeah.
So if you start talking about GDP, you can obviously blame the migrants for that, but it's possible there's something else wrong with the Turkish economy. And you know, oh yeah, well that's down to the migrants, but it's not clear that that's true. So like all these things, they have to be handled carefully. But obviously what you say is true, it's essentially a human rights issue and rubbish human rights. Rubbish in some places, but moderate rubbish.
If I may, something else that I think is relevant to your dilemma, what the in our Rome meeting, we had case studies from many parts of the world of responses to migrants. And one thing that emerged very clearly from that is that you can have response at different levels. It may be the whole times, especially in very different. Well, the South has been relatively good in its treatment of incoming migrants compared with the much more reactionary northern states. A lot of the migrants move to the north because it's on their way to other places. Also, we saw some very interesting examples of cities making the real response. And one of the best examples of that was from Germany. And in Germany, the city health people, including the big charity, decided to take the initiative and to take the health services to the migrants, not wait. Mobile clinics and move them out to the refugee camps. A lot of the medical people volunteered to go there. And they set up vaccination buses to go around. That worked really well, and gradually the city authorities and then the state and the government all contributed resources to make these things more effective.
And one of the issues, thank you very much for your talks, one of the issues I think came out quite clearly for me was the need for more data and that we don't have enough evidence in order to sort of promote changes in health policy. And it's something that's come out in the comments as well, like yours, for example, Francis, this need for data. And I think in my experience doing research in migrant health, there's a clear gap in funding. And I think in any sector you're doing research, whether it's third sector or whether it's in academia, you know, funding is needed in order to actually get this data that we so much need. So I was hoping some of you could respond to what you think the funding landscape looks like right now for migrant health research, and also what you think is needed in order to make sure we can actually get the data to then change policy.
There's some new European money in Horizon 2020, which is a very big research program. Unfortunately, Britain's about to fall out of qualifying for that.
I think that's not true. So first, we're about falling out. We are meant to be part of Horizon 2020. That's just been agreed. But there is a sort of low-level prejudice against the UK. I mean, you can't prove it. But we are part of it. Now, I mean, I don't know, do you want to say something?
No, go ahead.
You sure?
You're on a roll.
I mean, this is obviously a big issue, and everybody wants more money from the research base. And there's obviously, we want our share, but there isn't any money put aside for migrant health or any obvious place to get it. And you know as well as I do really how hard it is to get the research councils, the Wellcome Trust, other places to give us large sources of money. And we are continually getting small amounts of money, which don't allow us to do big projects and don't allow us to take on really big questions. And that's why a lot of migrant research is quite snapshot. And if we get 2 years funding, we think we're in for a while. But we are trying to interact with the Wellcome and with other research councils to try and encourage them to, as you are aware, to take on something for migrants, and also to encourage different groups with different perspectives on the migrant problem and different skills to come together, ideally, in my view, across a range of countries to deliver an outcome. But in the short term, the migration funding landscape can be summed up in one word: bleak. But it is very important, and it's up to us as academics to try and persuade people that it's worthwhile. And it is complicated because in the UK in particular, where the research councils, their remit is driven a lot by government, and government finds the best way to deal with migrants is to avoid.
Yeah, I think.
What's the key thing to do in the Middle East?
Yeah, Britain's decision to not intervene militarily in Syria resulted in all that money going to DFID for funding gap in the humanitarian health response is also quite big. I feel that there's two issues at bay here. In countries closer to the areas of the humanitarian disasters, those countries are still, they see migrant health very differently to maybe how we see it in there. It's, large refugee camps. It's very politically charged. So, the calls for definite inclusion of migrant health in research actually are very cautious in
We
the
have
region.
good colleagues in Turkey who are very keen on research in the migrant camps, and they are currently in different jails.
It's completely instrumentalized, and no matter what data you produce, political parties will use it to their political advantage. And I've known of research groups who were not given approval to do certain research in Iraq during the 90s, just in case it showed that the sanctions were having a bad impact on the Iraqi healthcare system, and therefore that would support, Saddam Hussein and so on and so forth. So, decisions around, there is an ethical kind of question around migrant health, and that I feel an ethical question becomes, has far greater consequences the closer you get to the source of the problem. And what's the...
I guess, but what I feel is that in no other research would you rely a lot, or people do rely, but you shouldn't rely on snapshots of people's opinions. And because people's opinions are very coloured. I mean, you talk about your graphic experience of walking around Lebanon, but that may be different to someone who's looking over what is the problem across the Middle East. Everyone's got, and the more you can inform it by either multiple people's opinions or, better still, facts, the more you are likely to be able to do something. There is a balance. It is complicated, but we know from the history of civilization is that people have had lots of, been absolutely convinced by things, which have held back the development of civilization by thousands of years. So I think you'd be a bit careful to say that we don't want to tackle it because it's too sensitive. I kind of think I might end up regretting that decision.
No, I mean, I think it should definitely be tackled. I think the approach to which you tackle it has to be very carefully thought out. It has to have,
I agree with that.
it has to be driven by kind of local actors. It has to be real buy-in from the community in which you're targeting. I mean, we're involved in the Atlantic Commission on Syria, and there's huge discussions as to whether we could be doing more harm than good in simply the way we describe the Syrian government, for example, in our research. Do we call it a regime? All of these have massive ramifications to the authors on the paper and their affiliates and their institutions where they come from, and it's very heavily driven. And I'm sure the Rohingya people as well. Any intervention is being seen as taking sides politically. What are the ethical implications of that to the population? Those discussions.
First, thank you for your presentations and for being here. I had a comment about the numbers that were shown, the number of refugees in countries in the Middle East like Jordan, Lebanon, Turkey. And I think for Jordan it was like around 600,000. And I think I read somewhere that there's a debate that there are estimates where the refugee population is, I think, around 1.5 million, and that's because some of them weren't really registered through the UNHCR or the United Nations since the beginning of the Arab Spring, which was 2011. So, but that would be interesting to see, comparing those actual estimates to the number of refugees in Europe, because I'm guessing the numbers in Europe are probably more exact, since they need to register in order to migrate to Europe. But I might be mistaken, I'm not sure. But that would be so that's something that that's always been debated about in Jordan and Lebanon and Turkey, that it's around the millions. But my question, I guess, is about, so what do you, it's a general question, what you see the future of the refugee health crisis, I guess. What is there data or evidence on the rises in particular diseases like TB, and how does that data or predictions, how will they impact health economies in Europe? So really, what do you see the future of refugee health?
To kind of draw on your first comment, I think, you know, population politics in the region is massive. You know, the Lebanese government asked UNHCR to stop registering refugees, or stop counting the number of refugees after they hit 1 million. We think the number's around 1.5. At the same time, we think Turkey and maybe Jordan could be overinflating their numbers, with problems due to deregistration, to kind of gain more sympathy from the international community and therefore gain more money. So just finding out the denominator of what the problem is absolutely massive, and that's, I guess, a world of kind of conflict research and humanity. As to the future of kind of refugee health, I think, you know, how much time have you got to discuss? I mean, I know there's been a lot of emphasis on infectious diseases. I see chronic diseases being refugee health agenda. Within the Syrian population, at least, I wasn't fully convinced that TB rates were soaring, and mainly because Syrians come from a middle-income country where areas of the world. You know, there needs to be a change in the narrative with respect to refugee health. I think in medicine we've stopped calling people, you know, asthmatics and diabetics, and we've started to call them people with asthma. All for the same thing with respect to migrants. They are people who have migrated rather than migrants and refuge. You know, humanizing the issue will go a long way to reducing the stigma, be it a felt or perceived stigma, and will kind of promote innovation and policies that will are more.
Very, very good point. So how are you getting on with it?